Nearly 50% of U.S. adults have high blood pressure, but fewer than half of adults have it controlled.
Hypertension is one of the most prevalent conditions that we see in this population, and so that's where we really saw the need in the community.
Barriers to hypertension management for our patient population can vary from cost of medications, education to understand why it's important, especially if they don't have symptoms of high blood pressure.
Target BP helps healthcare organizations improve blood pressure control by providing professional education resources, quality improvement tools, and annual achievement awards.
We've used the Target BP resources in several different ways, not only for the patients, but also for our team here. We've used them to help educate not only the providers, but also the medical assistants when checking patients' blood pressure.
So tools that have been very, very helpful for all of our staff is patient positioning poster for taking a blood pressure at home. So we now have those in all of the rooms, and it serves as a great reminder for staff to make sure that patients are positioned properly.
We had one medical assistant. She'd been working as a medical assistant for about 20 years. She's like, nobody ever told me this. I've been taking blood pressures wrong for 20 years.
Another pamphlet is in multiple languages, so of course English, Chinese, and also Spanish. And it shows the best tips, healthy eating, lifestyle, how to best measure your BP.
And then we typically print off the resources for patients as well so that they know how to adequately check blood pressure at home.
When patients start sending results into the clinic, the nurse will take that information, have communication with the provider. It's just stimulating more communication on a frequent basis.
But Target BP is really about like the whole health center. It starts even at the front desk, to the call center, to our dietitians, our pharmacists, our medical assistants, our nurses. Really everyone involved in the patient's care plays a role when it comes to Target BP.
Patients are thrilled real time in a week or two that they can see that their lifestyle changes or their med changes are making a difference.
In the past year, we've seen an increase in well-controlled blood pressure from 72% to 80% of our population.
We were about 52, 53% hypertension control and improved that to 80%. It's been great for everybody.
Join the growing Target BP community to improve blood pressure control for patients nationwide.
Welcome to the Target BP webinar featuring the 2025 American Heart Association and American College of Cardiology Guideline for the prevention, detection, evaluation, and management of high blood pressure in adults. With registration numbers that have exceeded 3,500 health professionals, I think it's fair to say that today represents a step toward a renewed focus on blood pressure control. I'm Allison Smith. I'm the Initiative Director for Target BP, and on behalf of the American Heart Association and the American Medical Association, thank you for joining us and really sharing our goal to prevent and control high blood pressure. We are thrilled to have students, clinicians, multidisciplinary team members, and leaders join us from across the country today. From universities, health systems, private practices, federally qualified health centers, and primary care associations. We really appreciate the efforts of so many local champions that have filled break rooms and classrooms and lecture halls today, so we can rapidly disseminate the latest guidelines and recommendations. So thank you. I do want to cover a few housekeeping items before we get going. We want to encourage you to adjust the accessibility features to meet your needs and preferences. This includes closed captioning and the adjustment to your primary language of choice for translation. We want to mention that the presentation will include case questions and poll questions along the way as time permits. We really encourage your participation. We welcome your questions at any point during the presentation today. So use the Q&A tab to write your questions to the speakers, and we'll do our best to address as many as we can, either in writing or verbally during the end discussion. With so many participants today, we suggest that you upvote questions that you share with another participant, and that will help us prioritize the most common questions to the top of the list. I also want to draw your attention to the resource tab at the bottom of the screen. It includes links to other guideline resources and Target BP quality improvement tools that will help support the translation of science into practice. Again, this event is being recorded and it will be available on targetbp.org shortly. At the end of the program, we'll share a link to claim continuing education credit. And with that, I want to acknowledge and share our joint accreditation statement that will provide credit for physicians, physicians associates, nurse practitioners, and pharmacists. Today, our learning objectives really include our goal for describing blood pressure thresholds for diagnosis and treatment, listing cardiovascular and cognitive risks of uncontrolled blood pressure, calculating cardiovascular risk as part of your care, and utilizing appropriate medication classes and combination pill forms to improve control and adherence. Our event today will begin with an overview of the guideline. Then we'll dive into addressing patient evaluation, prevention strategies, and treatment strategies based on the level of risk and other nuanced conditions. And then with the time remaining, we'll try to address as many of your questions as possible. Again, please use the Q&A function at the bottom of your screen whenever you're ready, and we'll get to as many of your questions as we can. Now it's really my honor to introduce our speakers today. Dr. Dan Jones served as the chair of the Guideline Writing Committee. Dr. Keith Ferdinand served as the vice chair of the Guideline Writing Committee. Dr. Jordana Cohen served as a writing committee member, and Dr. Wanpen Vongpatanasin served as a writing committee member. Each of these tireless hypertension control champions has extensive academic, research, practice, and leadership accomplishments, and they serve on innumerable professional volunteer committees and with other organizations across the country, and have humbly urged me to stop here so that the learning can begin. So with that, it's my pleasure to turn the podium and the stage over to Dr. Dan Jones. I did want to just briefly mention the disclosures for each of the speakers for conflict of interest, as well as our AHA AMA disclaimer. So with that, Dr. Jones, please take it away.
Allison, thank you so much. And my heartfelt thanks to each and every one who are watching and listening on the webcast today. I can't tell you how much it encourages me to have so many people who are interested in managing high blood pressure in your patients and getting them to control rates. Let's have our next slide, please. So this is the 2025 AHA ACC blood pressure management guideline. Many supporting organizations, as you can see. Next. I want to remind you that there is a new blood pressure guideline published every few years, the last one in 2017, and the 2025 guideline is a revision of the 2017 guideline. So you don't have to forget everything that you've learned before about high blood pressure management. Next. So I want to thank the members of the writing committee, 28 members who worked for roughly 18 months to digest all of the new evidence regarding high blood pressure management and distilled it for you in this guideline. I want to thank especially my vice chairs, Keith Ferdinand and Sandra Taylor. You'll be hearing from Dr. Ferdinand after me, and Heather Johnson and Daisy Shimbo, who are part of the leadership team as well. Next. So don't worry about the complication of this slide, how busy it is. It's there in the published guideline if you want to take a look at this. It is simply an accountability tool. It allows us to tell you how strong the evidence is that backs up the recommendations that we're making you in the for the management of your patients. So you'll see class of recommendation and a level of evidence expressed in numbers and letters. Simply an accountability tool. Next. So I want to assure you, even though, as Allison noted, the four of us who are presenting today have academic appointments. We teach in medical schools, etc. But let me assure you that we are all clinicians. We all take care of patients. So this guideline was written by clinicians, for you as clinicians, and for your patients, with strong evidence-based but with practical application for clinicians and for patient care. Next slide, please. So just some thoughts about how you can use the guideline. I hope that many of you will read it from front to back, that you'll digest it and consider it an update on how you manage blood pressure. Remind yourself of some of the things that you've studied and learned in the past. And again, it's a rather long document, but it's a good document for an update for you. If you don't have that kind of time right now, some ways that you can dig into the guideline in the immediacy is to look at the top 10 takeaways and what's new. These are in tables in the very front of the guideline. You can get to them easily. All through the guideline, there are boxed recommendations. And you can look at those, you can flip through the guideline and look at the boxed recommendations and get the core of what the guideline committee recommends for you in patient management. And then you can do as I do with each guideline as it comes out. Print a copy, put it at a convenient place in my office, and then when I come across a patient who perhaps challenges my remembrance of all of the things and the subtleties of managing a patient with hypertension, then I can look back, look at the table of contents and find, if I'm looking for that patient, information about maybe how do I evaluate a patient I think may have primary aldosteronism. I can remind myself what is the beginning place, what are the tests that I need to do to begin that. So it's good for a reference. So let me just say to you as one clinician to another that I know change is hard. We learn how to do things early in our career and we get comfortable with those things. And it's so easy just to keep doing the things as we've always done them. The guideline is based on the most recent evidence that will provide your patients with the best opportunity for getting to goal and give your patients the very best opportunity to reduce their risk for the things that they don't want to experience. Heart attacks, heart failure, strokes. We'll talk more about this later, but dementia, yes, lowering blood pressure reduces the risk of dementia. Next slide, please. So here are three key numbers for all of us to keep in mind as we're digesting the guideline and thinking about management of our patients. The three numbers are the blood pressure categories. Those are unchanged in this guideline. We'll look at them in just a moment. The blood pressure threshold tells us where to initiate medication. And this in this guideline is based on the total cardiovascular risk for the patient. Again, we'll talk about that again in a moment. And then the important blood pressure goal. And those are the three numbers that you need to keep in your mind as you're thinking through managing a particular patient. What is the patient's blood pressure? So what is the classification of this patient's blood pressure? What is the threshold? When am I going to start medication on this patient? And as I begin medication and lifestyle therapy, what is my goal treatment for the patient? Next slide. So here are the familiar to you blood pressure categories, and I'll focus on systolic blood pressure for simplicity as I go through this chart. Normal blood pressure is less than 120, and that is a normal blood pressure for anybody at any age. If the blood pressure is higher than that, then it's not normal blood pressure. Elevated is 120 to 129. Stage 1 hypertension, 130 to 139 millimeters of mercury, and stage 2 hypertension, 140 millimeters of mercury or higher. All those above that are in stage 2 hypertension. Those categories drive some of our decisions around when to start medication therapy. And next slide. So the blood pressure threshold for the 2025 guideline is very similar to what you've used since the publication of the 2017 guideline. For patients who are above 140/90 or have stage 2 hypertension, all of those patients get started with lifestyle therapy plus medications to begin with. And for most of those patients, you're going to begin with 2 medications and ideally 2 medicines and 1 pill combination therapy to help the patient get started with managing their blood pressure and getting to goal blood pressure. For patients with stage 1 hypertension, those are systolic blood pressures between 130 and 139. If the patient is at low risk, has no history of cardiovascular disease or chronic kidney disease or diabetes, and their calculated risk score, now we're using the prevent risk score, they'll be more about that later in the presentation and lots about it in the guideline itself. If the risk score is less than 7.5% for their 10-year risk, you begin those patients with lifestyle therapy alone. Continue to monitor them both in office blood pressure and home blood pressure. And at 3 to 6 months, if blood pressure goal of less than 130/80 is not met, that's the place to begin the medication in these patients. This will result in a few more patients being on medication, but it's based on the strong evidence that lowering blood pressure and lowering blood pressure early in the course of hypertension reduces the risk for all of those bad things that hypertension is associated with. Next slide, please. And the goal blood pressure is a little bit different than the 2017. The language that we use in the 2025 guideline is this, that we ask you to get blood pressure at a minimum to less than 130/80 for all of your patients. Of course, always using your own clinical judgment, patient to patient. But then we add the phrase with encouragement to achieve less than 120 millimeters of mercury. This is for both your young patients and yes, for your older patients as well. Most of the studies that have been done that have addressed the issue of is 120 millimeters of mercury or less a good goal blood pressure, those have been done mostly in older patients and have demonstrated both the utility, the reduction in risk of cardiovascular disease and kidney disease, etc., but is also safe. The benefits of lowering blood pressure to this range far outweigh the risk to your patient. Does it require some good clinical management? Absolutely. It requires in those older patients for you to go low and slow. For younger patients, you can go a little bit faster. And it always, as you look at a guideline recommendation, always includes your clinical judgment as well. So this year, we're beginning with a new set of goals, at least 130/80, and with encouragement to achieve less than 120 millimeters of mercury. Next, please. So here it is. This is just to let you see what the boxed recommendations look like in the guidelines. And this just gives you the level of evidence for both those who are at increased risk for cardiovascular disease and those who are at lower risk. But for all of these patients, the goal is at least 130/80 with an encouragement to achieve less than 120. Next slide, please. So a couple of questions for you. Be sure you're still awake today. Here it is. A patient is taking low-dose ACE inhibitor and feels well. Comes back for a routine evaluation of the blood pressure. Home blood pressure over this last 3 months. Average blood pressure at home, 116/72 millimeters of mercury. Office blood pressure on the day that you're seeing her, the average of 3 readings is 132/82. The next best step for this patient is to increase the medication dosage of the ACE inhibitor, or to add a diuretic, or to continue the present medication. Let me pause and see what you think about this question. 86% of you say continue the present medication, and that is great because, next slide please, indeed, that is the appropriate thing to do. The office blood pressure is a little bit above goal, but gee whiz, look at those great home blood pressure measurements over the average of 3 months. And it is the home blood pressure that is the stronger prediction than the office blood pressure for how the patient's outcome will be with cardiovascular disease. Next slide, please. So in the boxed recommendations that we give you about this, both for diagnosing hypertension and for monitoring the blood pressure for medication adjustment, home blood pressure measurement is such a valuable tool. And I do highly recommend that every one of your patients who has high blood pressure be taught to measure blood pressure at home with a good, validated device. Next, please. And the last question, patients with a newly confirmed diagnosis of hypertension should have the following initial test: an echocardiogram, a urine albumin to creatinine ratio, renal vein renin level, or a 24-hour urine for protein. Let me pause here and let you vote. Wow, I am impressed with the knowledge of the audience. 85% with the correct answer, urine albumin to creatinine ratio. Next slide, please. This test is the only new test that we recommend for the evaluation of the new patient with hypertension. You see all of the things that have been there in the past. The urine albumin to creatinine ratio gives you an earlier indication of chronic kidney disease than the serum creatinine can. And so this is such an important test. It's available everywhere now. It's not terribly expensive, and it's such a valuable tool in picking up chronic kidney disease at an early stage. And my last slide, next slide please, is I saved my best news for last, and I'll emphasize this one. Since the 2017 guideline was written, we've gone from we think lowering blood pressure reduces the risk of dementia to the absolutely we know for sure that intensive lowering of blood pressure reduces the risk of dementia. Isn't that such great news for your patients and for your practice? Not only does lowering blood pressure prevent heart attacks and strokes, but reduces the risk of dementia by 12 to 19%. Thanks so much for listening to my part of the presentation. And now I turn this over to my friend and my colleague, Dr. Keith.
Thank you, Dan. My video's not starting, but I'm going to keep going. Here we go. So I'm going to give you a case. This is a 34-year-old self-identified Black male. He's not ill. He comes in for a pre-employment physical. He's not aware of any prior history of hypertension, no cardiac symptoms, no obvious cardiovascular disease, doesn't smoke or use tobacco. He does like alcohol, drinks up to 3 cans of beer nightly, and he's not overweight or obese. So after you do proper technique, the blood pressure average 136/88, you do a risk calculator with Prevent. Now I'll show you how to use this tool. The cardiovascular risk score is 1.3%, which is considered low. You do the recommended routine laboratory studies, and there's no evidence of diabetes or chronic kidney disease. The Prevent online calculator takes into account the person's sex. This was a young male. The lipids, blood pressure, BMI, he was not overweight or obese. GFR, he had a normal GFR, no obvious evidence of kidney disease. Always ask about smoking, another potent risk factor, and the use of other medications. You'll note when you go online that they say that these other indicators can be used if available or clinically indicated, but for our guideline in 2025, we think everyone should get a urine albumin creatinine ratio. It's also called microalbuminuria. And in this particular case, it was checked and it was normal, less than 30 milligrams per gram. The hemoglobin A1C is elective. The zip code analysis will give you some analysis of the social drivers of health, where people work, live, play, and pray, and that can have a profound effect. In this particular case, we didn't enter those data, but he still calculates as low risk. His 10-year risk of CVD, 1.3%. So let's do a question. Here's this guy comes in for a pre-employment physical. He feels pretty good. Blood pressure done appropriately, 136/88. First, he has stage 1 hypertension. He needs medications immediately. Secondly, give lifestyle modification, limit his sodium, less than 2,300, but let him have his beers, up to 3 beers nightly. Next, wait 3 to 6 months after appropriate lifestyle modification, and if his blood pressure is still greater than or equal to 130/80, then start medicine. Finally, look at his risk calculator. It was quite low, so no drug therapy will ever be needed as long as he has a low risk. Let's see what you say. Wow, you guys have read the guidelines already. It suggested that the person get appropriate lifestyle interventions, and if the blood pressure remains 130/80 after 3 to 6 months, then start medication. And here are the various recommended lifestyle changes to prevent elevation of blood pressure and hypertension. Maintain or achieve healthy weight. We do a 2B indication that persons may need incretins or the GLP-1 receptor agonist in order to assist with that. A heart healthy eating plan. We think the DASH diet has the most robust long-term data. Reducing sodium intake. Now, the less than 2,300 is not ideal. We really would like you to push it even less, to 1,500. Self-substitute, and that's somewhat controversial, but it's a new indication for the lifestyle modification. And we have some data looking at, in China, a population where there was a decrease not only in cardiovascular disease, but total mortality. Now, these are persons who are using sodium in prepared foods at home or adding sodium many Americans have the sodium already baked into their food. Dietary potassium intake, perhaps the best way, and it's a surrogate somewhat for the DASH diet, unless the person has advanced CKD or drugs that will interfere with potassium excretion. Physical activity, both aerobic and resistance activity. Manage stress. There's a 2B indication for a person who's using meditation, and there's some other data for yoga that it may actually help these low-risk patients. Reduce or eliminate alcohol. Abstinence is best, but we know that most patients who drink are going to consume alcohol. For men, 2 or less, women, 1 or less alcoholic consumptions. Here's the table showing the decrease in blood pressure that you can see with some of these lifestyle interventions. I think reducing sodium intake, especially in the American population, is going to be very important. Many patients not only are not less than 2,300, but are consuming 5 and 10 milligrams of sodium on a regular basis. The salt substitute indication for a lifestyle modification is new. It's suggested based on those persons who prepare food at home or add sodium chloride at the table. And enhancing the intake of potassium, again, mirrors some of the benefit that we see with the DASH diet, which was rich in potassium. Now, for reducing alcohol, we know that the general recommendation is 2 or less drinks for a man, 1 or less for a woman, but we think abstinence is best. We didn't make it abstinence for all because we knew there would be a barrier to the uptake of this, but the data shows versus people who consume alcohol, those who abstain from alcohol tend to have lower blood pressures. Here's the box recommendation, 1A for DASH, and reducing sodium with an ideal limitation of sodium of less than 1,500 milligrams per day. Here's the box recommendation for alcohol, 1A. We recommend that you pursue abstinence, but if a person is going to consume alcohol, 1 or less drinks for a woman, 2 or less drinks for a man will prevent or even treat elevated blood pressure and hypertension. You know, in clinic, I asked a guy 2 weeks ago how much he drank, and he said only 1 or 2 at times. And when I asked him what exactly he was drinking, he was doing a double shot of his favorite whiskey. So you have to be very, very clear in your understanding when persons say what they're consuming. This is from the NIH, a picture of what is a standard drink. Now, let's go back to that patient. The patient was concerned, so he did the right thing, and he came back 3 to 6 months later. If the person has a low risk, less than 7.5% CVD risk, and I showed you how to calculate that, and the blood pressure remains 130 or above after 3 to 6 months, we then suggest medication. At the top, this recommendation would be for the systolic of 130 or above. At the bottom, the recommendation is for a diastolic of 80 or above. So the patient comes back in, he's done the right thing, he's got a home device. He used validatebp.org, which is a non-commercial site that will show the patient where they can get good devices that have been validated. After 6 months, he's 132 over 82. What we're going to do next? What medication you're going to use? Metoprolol tartrate 50, lisinopril 10 plus hydrochlorothiazide 25, amlodipine 5, or all of the above are appropriate as initial therapy. Well, it's kind of mixed on that one. I think the right answer is going to be the amlodipine 5 milligrams. As a first step for these low-risk patients, we think 1 medication is reasonable. We do know that combination therapy could be beneficial in this particular case, so that's not a wrong answer. And we would not use a beta blocker. It's not one of the classes for initial therapy. Plus, metoprolol tartrate is a short-acting form of beta blocker and probably would not assist with this patient. Here's the box indication for a low-risk patient. Thiazide type diuretics, that's a term of art that we've embraced, and it includes not only hydrochlorothiazide, but also chlorothalidone and indapamide. Long-acting dihydropyridine calcium channel blockers, we just have more robust data with this particular class versus the other calcium blockers. ACE inhibitor or ARB, we use them equally, especially in these low-risk patients. Now, if the person has a secondary or compelling indication. For instance, HFrEF, the ACE inhibitors, has more potent data, and perhaps patients post-myocardial infarction. But for the purposes of treating stage 1 hypertension, an ACE or an ARB. One of the questions that's already come into the box and I can answer is why we didn't recommend a particular drug based on race or Black. We think now that the most important thing is not to use race, which is to a large extent not really a genetic or a scientific category, but more of a social category, but to look at the underlying patient. If they have compelling indications, use the medications that's needed. And for patients who need combination therapy, it ameliorates or removes any differences that have been previously reported based on race. If he indeed had stage 2 hypertension, then we would start that patient on 2 agents, different classes, and we specifically suggest a single pill combination. It may actually improve blood pressure control and add to adherence. So let's look at the way that we're going to use the prevent record calculator and how we're going to approach these patients. First question, does the patient have a blood pressure of 140/90 or above? So is this patient stage 2? If the answer is no, and remember our patient was not 140/90 or above, the next question you ask was the underlying cardiovascular disease. Does the patient have coronary disease, stroke, or heart failure? And if you recall, the gentleman came in for a physical. He actually felt fine. There was no obvious evidence of any cardiovascular disease. Did the patient have diabetes or chronic kidney disease? The answer was no. And we did a calculation using Prevent CVD. The risk was less than 7.5. The answer is no. So 3 to 6 months, therapeutic lifestyle changes, and I've detailed a few of those, and you can get more information when you read the guideline. But after 3 to 6 months, we now have data that those patients don't stay stage 1. About 30% of them will go to stage 2. And there's even some data that suggests that they will increase the risk of target organ damage, specifically left ventricular hypertrophy, if left untreated. So at this point, we recommend treating those patients in order to reduce progression of blood pressure and target organ damage. You're going to hear more about those patients who are stage 2, have other complications that may predict which medications or which approach should be used. For the low-risk patient, however, we recommend 3 to 6 months. If less than 7.5, after 3 to 6 months, initiate drug therapy. The classes of drugs that we showed are based on observational data. All of those seem to be beneficial. The thiazide-like, thiazide-type diuretic, long-acting dihydropyridine, the ACE inhibitor, or ARB. On the other hand, you're going to hear next those patients who had higher risk, who may have a higher calculated prevent calculation, may have additional complications, stroke, diabetes, chronic kidney disease. There's a different approach for those patients, and we'll hear more about that, starting with 2 drugs, often in a single pill combination. So we have Jordy, and she'll talk about those patients who are more complicated. Jordy?
Thank you so much, Keith, or Dr. Ferdinand, for your amazing presentation. And so that's a perfect handoff for my opportunity to be talking about these higher risk patients as well as secondary hypertension. So I'm going to start off with a case of a 63-year-old woman with a past medical history of obstructive sleep apnea and CPAP and atrial fibrillation. She presented to my clinic with difficult to control hypertension, and after up-titrating her meds over several months, her office blood pressure is now 134/78. On a fixed-dose combination or a single pill combination of valsartan, amlodipine, and hydrochlorothiazide at maximum dose, as well as metoprolol succinate 50 milligrams daily, which had been started for her atrial fibrillation. Which is the next best course of action for this patient? Would it be to start the spironolactone 25 milligrams daily, check a plasma renin and aldosterone, hold her blood pressure meds for 30 days and then check a renin and aldosterone, or replace her blood pressure medications with hydralazine and diltiazem for 30 days and then check a renin and aldosterone? Excellent. So more than half of people got this correct, which is to check plasma renin and aldosterone. I do appreciate that a large portion of people suggested to empirically start spironolactone 25 milligrams daily, which I think would be a reasonable alternative if you don't feel that it will change your management in somebody. For instance, if they're not interested in potentially pursuing surgery, if they are found to have primary aldosteronism. Because we found in the literature that people do not empirically start mineralocorticoid receptor antagonists typically in these patients, less than 15% of people do. This is why we think that screening will be an incredibly important step in order to think more towards actually checking whether or not they have primary aldosteronism. Next is a 42-year-old man with no past medical history who is new to our clinic. 6 months ago, he had blood pressures in the 140s to 150s over 90s that were checked using careful technique at 2 office visits and were consistent with his home blood pressures. He was started on olmesartan and amlodipine 45 milligrams daily in a single pill combination. Which is the appropriate next course of action in this patient, or a potentially appropriate one? Check plasma renin and aldosterone, hold his blood pressure medications for 30 days and then check renin and aldosterone, or replace his blood pressure medications with hydralazine and diltiazem for 30 days and then check renin and aldosterone. Correct. And so I think this one was a little bit more of a leading question, but the 80% of people got this right to check the renin and aldosterone. There's a substantial number of people who did choose C, which is replace his medications with hydralazine and diltiazem. This used to be a recommendation that was commonly practiced, but growing evidence supports that most medications are not going to dampen your ability to at least determine if somebody has primary aldosteronism on initial screening in the majority of individuals. And if you have a high level of suspicion for primary aldosteronism, like in our prior patient who had very resistant hypertension, then you can take additional steps to subsequently hold their medication to do more confirmatory testing or repeat testing. And so I'd like to go through our recommendations with regard to screening for secondary hypertension first, and then I'll dive deeper into primary aldosteronism. And so in adults with hypertension, the guideline has a level 1 recommendation that's based on expert opinion to screen for specific forms of secondary hypertension when clinical suspicion is present, and a 2A recommendation that in those with positive screening, it would probably be a good idea to refer individuals to a clinician with expertise in hypertension or in that specific type of secondary hypertension. This is a comprehensive list of the particular indications that would be considered to test for secondary hypertension. I'm not going to go into these in extreme detail, but I'll bring up the most common reasons to check for secondary hypertension, which include resistant hypertension, which Dr. Vongpatanasin, who's speaking next, will go into more detail. People who have abrupt onset or worsening of hypertension, as well as young onset hypertension. These tend to be the most common reasons that we consider screening people for secondary hypertension. So if they do have one of these indications, we should be screening them for primary aldosteronism as well as other secondary forms of hypertension based off of their history and our level of suspicion. If they do not have a positive screening test, we can enhance their medical therapy and think about using second and third line agents in these individuals. And those who do have positive screening tests, those are the individuals that we would refer to a clinician with specific secondary hypertension expertise. Diving into primary aldosteronism in particular, the guidelines did continue to have the prior guideline recommendation that was in the 2017 guideline with a level 1 recommendation that people with resistant hypertension, obstructive sleep apnea with hypertension, incidental adrenal mass with hypertension, as well as family history of early onset hypertension or stroke at a young age should all undergo screening for primary aldosteronism. What's new in this set of guidelines is first off an emphasis, which Dr. Vongpatanasin may also touch on, that even regardless of whether somebody has hypokalemia, we should still be screening them for primary aldosteronism in the presence of hypertension. Additionally, there's a new level 2B recommendation that in individuals with stage 2 hypertension, so blood pressure greater than or equal to 140 or over 90, that we should be screening for primary aldosteronism, or at least considering screening in these individuals based on increasing data supporting a high prevalence of primary aldosteronism, even in the general population of stage 2 hypertensives, that's somewhere in the range of 10 to 15% of these individuals. The way that we should be screening for primary aldosteronism is to perform a plasma aldosterone. We highlighted recommending renin activity because this is the most systematically consistent lab test where the ranges are consistent across labs, whereas direct renin varies from lab to lab and makes it a bit more difficult to interpret, in addition to the plasma aldosterone and renin activity ratio. And so the way that these are typically interpreted is that individuals need to have an elevated plasma aldosterone, which is at least greater than 10, a renin activity that's suppressed, which means needs to be at least less than 1, in addition to an elevated aldosterone to renin ratio, which is typically considered elevated at 30 to 1, but some guidelines range that from anywhere to 20 to 40. What our recommendation is to just essentially do these off the bat, and then if you need additional help or additional assistance with interpretation or management, to then refer to a hypertension specialist. We recommend continuing most antihypertensive medications when screening, as I mentioned earlier, because growing evidence supports that when people are on other antihypertensive medications and they need to be stopped for screening, it creates a barrier to screening, and it doesn't necessarily help with interpretation, except in certain circumstances where repeat testing can be done off of those medications if there's a high level of suspicion and concern that the medications could be impacting the interpretation. In individuals who have a positive screening test, then we would recommend referring these individuals to a hypertension specialist or endocrinologist for further evaluation, such as adrenal vein sampling. We recommended primary aldosteronism screening, again, because this is very, very highly prevalent in individuals with hypertension, ranging from 5 to 25% prevalence, depending on the severity of hypertension. Obstructive sleep apnea is also extremely common in these individuals, ranging from 25 to 50% of individuals with hypertension. Chronic kidney disease is incredibly common, as mentioned by Dan earlier in his talk, and this is why there's this new recommendation to screen individuals with the urine albumin to creatinine ratio, not just an eGFR, at the time of diagnosis of hypertension. Drugs and alcohol are also an incredibly important cause of secondary hypertension. As Keith had discussed the important role of alcohol, I did want to emphasize it here as well, because we really should be thinking of this as a secondary cause of hypertension as well, and discussing with our patients the importance of considering abstinence if they're able to, or at minimum limiting their alcohol to no more than 1 drink daily in men and no more than 2 drinks daily, no more than 1 drink daily in women and no more than 2 drinks daily in men. A couple of other drugs I just wanted to highlight. Of course, this is not an exclusive list, but one that's new that I did want to make sure people are aware of is that suddenly withdrawing centrally acting sympatholytic drugs has been a well-known cause of secondary hypertension for a long time. Specifically, we know that clonidine, if you suddenly stop it, causes a rebound hypertension. But most people, I think, aren't aware that tizanidine is the exact same mechanism of action and is actually a shorter acting version of clonidine. It's very commonly used as a muscle relaxant now for individuals, for example, with severe back pain. We've also seen it used as a potential treatment for migraines or prophylactic for migraines. And when this is used as needed, or just once daily, or just intermittently, it can result in very labile or severe withdrawal hypertension. It's been associated with stroke and with hypertensive encephalopathy. And so we do strongly recommend considering this when thinking about secondary causes of hypertension. One other thing I wanted to highlight was oral contraceptives. Oral contraceptives, I think everybody is very well aware, are a common cause of secondary hypertension, particularly ones with higher doses of estrogen in them. One thing I do want people to consider, though, is of course we should be holding those estrogen-containing oral contraceptives in women who are on oral contraceptives and whom we're concerned for a possibility of that causing their hypertension. But please don't leave them without a form of contraceptive. Please consider either a lower dose estrogen-containing agent or a progestin-only form of contraception to ensure that they do have protection while they're undergoing evaluation for their hypertension. So my next case is a 68-year-old woman with a past medical history of well-controlled type 2 diabetes. Her office blood pressures at 2 visits were 134/84 and 136/88, which were also consistent with home blood pressure readings ranging in the mid to high 130s/80s. Her body mass index is 24, so normal. Her labs were significant for a normal potassium of 3.9, an estimated glomerular filtration rate of 55, so that's slightly lower than normal, and a urine microalbumin of 86 milligrams per gram, so slightly above normal. What would be your next course of action? Continue to monitor, start lisinopril, start finerenone, or start semaglutide? Great. And so the majority of people chose to start lisinopril. I think in the nephrology world right now, given that I'm a nephrologist, there's some controversy over this, as some individuals do think that these newer agents, since they lower blood pressure a small amount, would potentially be a superior option. But based on our best evidence, most people were on background ACE inhibitor or ARB therapy in the trials that evaluated these drugs. We still need to stick with the basics. And this is a hypertensive patient. We should be thinking about making sure we're optimizing their hypertension risk. And so we do recommend starting with lisinopril. It should be initiated at a systolic blood pressure greater than or equal to 130 in individuals with type 2 diabetes and hypertension, with a treatment goal of less than 130, again, given her elevated risk and that type 2 diabetes is an atherosclerotic cardiovascular disease risk equivalent. We would encourage somebody like this to also consider achieving a blood pressure of less than 120, considering, for example, the BP road results, to reduce their cardiovascular disease morbidity and mortality. In adults with type 2 diabetes and hypertension, all first-line classes of antihypertensive agents are appropriate. In this particular individual, as we show here in the third line, ACE inhibitors or ARBs are particularly recommended given her lower eGFR, that's less than 60, and her albuminuria. If they have either one of those, we typically would consider starting individuals with an ACE inhibitor or ARB. For the albuminuria in particular, it helps to delay progression of chronic kidney disease. In an individual who is overweight or obese with a body mass index of 27 or greater, we would also consider a GLP-1 agonist as a reasonable alternative in an individual like this, as it may also be quite a substantial adjunct to lowering blood pressure as well, along with the weight loss. However, given that her body mass index was normal, it was something that would likely be premature for somebody like this. This woman also has chronic kidney disease, and so we do have specific recommendations for the management of hypertension in individuals with chronic kidney disease, which, similar to type 2 diabetes, is an atherosclerotic cardiovascular disease risk equivalent. And so in someone like this, similarly, the blood pressure goal would be less than 130, regardless of her diabetes status. And because of her albuminuria, we'd be strongly recommending an ACE inhibitor or ARB, not just for the lowering the risk of chronic kidney disease progression, but also because these drugs have been demonstrated to decrease the risk of cardiovascular disease. And so that is an incredibly important reason to be even considering these drugs in individuals without albuminuria as well, but the data there is not quite as strong. One important caveat, of course, is not to treat people with both an ACE inhibitor and an ARB at the same time, as that can introduce harm from hyperkalemia and acute kidney injury. And so next, I'm going to be passing the baton to Dr. Vongpatanasin.
Thank you, Dr. Cohen. I'm going to dive into the first case related to the topic I discussed. So we have a 43-year-old female with history of hypertension, migraine headache. She's here for yearly checkup with her PCP. Her office blood pressure is 185 or 110. She forgot to take her medication last night, which consists of losartan, 50 milligram, and hydrochlorothiazide, 25 milligram daily. She feels fine otherwise. She's somewhat surprised by her readings. The rest of her examination is unremarkable. What is the next course of action? First, resume losartan and hydrochlorothiazide in the clinic and observe in the clinic for 3 hours. B, start clonidine PO in the clinic and remeasure blood pressure in 1 hour. C, refer patient to emergency department to start intravenous medication promptly. D, ask the patient to resume medication at home and return to clinic follow-up in 2 weeks. So I think majority are doing well. There's still a lot of different opinions. So I think this is a good to dive on. So the answer is actually resume medication at home and return to clinic in 2 weeks. So the rationale for that is that the blood flow in the vital organs, such as the brain, the heart, and the kidney, usually is maintained at a constant range by the process called autoregulation in the brain. The cerebral perfusion pressure is mean arterial pressure minus intracranial pressure, and the blood flow is reasonably maintained at a wide range of physiological pressure to allow us to function in normal physiological state. Normal intensive individuals probably around 160 to 120, but in the presence of uncontrolled hypertension, this pressure flow relationship might be shifted to the right, perhaps around 110 to 180 range, and acute lowering of blood pressure in these individuals might cause a decrease in flow to the vital organs, which may not be warranted in asymptomatic patient. And so the guideline has, take a second. So the guideline has now provide the guidance when facing with patient with systolic blood pressure of more than 180 or diastolic of 120 or more. The first question we should ask ourselves is, does the patient have acute target organ damage? Meaning, does the patient have acute neurological disorder such as PRES, encephalopathy, stroke, acute cardiac emergency such as acute decompensated heart failure, acute coronary syndrome, acute kidney injury, acute aortic syndrome such as penetrating aortic ulcer or aortic dissection that would warrant acute lowering of blood pressure. And if the answer is yes, then the patient have hypertensive emergency and should be evaluated promptly in the ICU setting, particularly with the compelling indications such as aortic dissection of pheochromocytoma. The target of blood pressure reduction for aortic dissection probably is the most urgent emergent indication to try to get it low below 120 millimeter mercury within the first hour if the patient can tolerate. And for pheochromocytoma crisis, less than 140 millimeter mercury in the first hour. If the patient without any this compelling indication, majority of the time the blood pressure can be reduced by 25% in the first hour and to less than 160 or 100 to 110 in the next 6 hours, and to the try to get to a normal to the target range in the next 24 to 48 hours. I would caution that this is not applicable to hypertensive disorder or pregnancy or stroke. The detail of blood pressure lowering in this condition can be found in the guidelines. If patient does not have acute target organ damage, patient would be fit in the category of asymptomatic severe hypertension. If this is identified in the emergency department, the decision to admit the patient is not depending on blood pressure alone. It depends on other indication beyond blood pressure. And in this setting, actually the guideline caution against a parenteral medication or intensified oral therapy to lower the blood pressure for the same reason that I mentioned earlier. If the patient is identified to have elevated blood pressure in the outpatient setting and patient is totally asymptomatic, there's no need to refer patient to emergency department. We can reinstitute therapy and intensify medical therapy with a close follow-up. So I'm going to move on to the next case. Question, this is a 56-year-old gentleman with history of hypertension, osteoarthritis, class 2 obesity, who's referred to see a hypertension specialist. His blood pressure in the office, 144/95, and he said it's very similar to be at home. And he's report taking medication prescribed regularly. It's a combination pill, telmisartan, hydrochlorothiazide, 80/25, and amlodipine, 10 milligram daily. His serum potassium is normal. His eGFR is mildly reduced. What is not correct course of action? Emphasis on not. A, review patient list of over-the-counter medication. B, obtain serum aldosterone and plasma renin activity. C, add spironolactone 12.5 milligram daily. And D, prompt referral to renal denervation. Oh, wow, it's interesting. Okay, wow, very interesting. Okay, so 74% once you refer a patient to renal denervation, I think it's that's good. Actually, that's the correct cause. That's prompt renal denervation is should not be is the first choice. So so the definition of resistant hypertension is unchanged from previous, and which is uncontrolled blood pressure on 3 or more drugs, which is the ACE or R plus CCB plus thiazide diuretics, or controlled blood pressure on 4 drugs. This is unchanged from 2017 guidelines. The first step for evaluation is to exclude pseudo-resistant, such as white coat hypertension. The patient actually reported home blood pressure is the same, so it's unlikely, and the patient report taking medication, know what he's supposed to take, so the adherence issue is less likely. Then we should think about identifying reverse contributing lifestyle factors. He has obesity, so this is something that can be worked on. And importantly, the guideline recommend to review medication for interfering substance. He has history of severe knee pain, so perhaps maybe taking NSAID, and might not be on the drug list because it's an over-the-counter medication. So important to ask the patient. And other than that, so also to think about screening for secondary hypertension. So in this case, obtaining plasma renin activity and aldosterone would be appropriate, as Dr. Cohen mentioned, that even in the absence of hypokalemia, the presence of resistant hypertension alone should be indication for screening for primary aldosteronism. And then if all this algorithm has been followed, then intensify optimization of medication should include thinking about replacing thiazide type diuretics with longer acting thiazide, like such as cloxalidone or indapamide, and add the mineralocorticoid receptor antagonists such as spironolactone or pleurinone if eGFR is at least 45. In these guidelines, amiloride can be used if patient cannot tolerate MRA as a 2A. And in patient with stage 4 or 5 CKD, cloxalidone could be considered as stage 4, and loop diuretics also can be used. And then if the blood pressure is not controlled despite this, then consider adding agent with different mode of mechanism of action. I'm not going to go through all of them, but these are the lists of possible add-on as the 5th drug. And if the blood pressure remains uncontrolled by more than 6 months, or there is continuous suspicion for secondary hypertension, the patient should be referred to specialists with expertise in management of hypertension, the persistent hypertension. And so this is a summary of the guidelines that detail assessment of secondary cause, review of medication, removal of this interfering agent is important, and add AMRA is recommended as class 1 recommendation. Also, the guidelines does provide the indication or selection for patient with renal denervation should be stage 2 hypertension with both systolic of at least 140 and diastolic of 90. That's because that's the criteria used in clinical trial. And if the blood pressure is still not controlled despite taking 4 drugs that include the ASR plus CCB, thiazide diuretics, and MRA, or if the patient have stage 2 hypertension, the same blood pressure criteria, who are unable to take medication at optimal dosage. The contraindication is neurogenic orthostatic hypotension, usually mean about autonomic failure, so probably doesn't make sense to try to denervate the nerve when sympathetic nervous system is not functioning properly. Pregnancy, renal anatomic exclusion, including a stented renal arteries is a contraindication. Patient with non-kidney or adrenal secreting tumor should be also a contraindication. So moving along, I'm going to go to the last case question. We have a 75-year-old lady with history of hypertension and well-controlled type 2 diabetes who was seen in her PCP at the usual follow-up, and her seated blood pressure is 152/72. heart rate of 64. When she stood up, her blood pressure is 118 over 68, heart rate of 67 without any dizziness or symptoms. She's actually very active senior. She can exercise by swimming twice a week. And her current medication include clothalidone 25 milligram and amlodipine 10 milligram daily, which is the correct statement. A, clothalidone should be reduced to avoid orthostatic hypotension. B, intensive lowering of blood pressure may increase the risk of fall or injury. C, addition of losartan 25 milligram may reduce orthostatic hypotension. And D, the risk of lowering systolic blood pressure to less than 130 millimeter mercury outweigh the benefit in this patient. Let's see. Okay, the answer is a bit mixed. But majority is a concern about intensive lowering of blood pressure. Let's see what the answer is. Actually, the answer might be a little bit surprising to a lot of audience. Addition of losartan 25 milligram may reduce orthostatic hypotension. So in these guidelines, the class 1 recommendation is improved blood pressure control is recommended to reduce the risk of orthostatic hypotension. And there's a class 2A recommendation that intensive lowering of therapy in asymptomatic orthostatic hypotension with the goal of less than systolic blood pressure of less than 130. It's reasonable due to benefit in lowering cardiovascular risk and mortality. And this is based on a meta-analysis by Dr. Joshek group from a landmark clinical trial, including AASK, Accord Sprint, that showed that if anything, intensive lowering of blood pressure reduced the risk of orthostatic hypotension with the odds ratio of 0.93. But I think there's a caution, at least, that patients enrolled in clinical trial are typically healthier and they are not frail. So there's a recommendation that if the patient have symptomatic orthostatic hypotension, I think that's very reasonable to assess orthostatic blood pressure. If they have symptoms of dizziness, they have history of fainting and falling, that needs to be assessed and addressed, as intensive lowering of blood pressure may exacerbate the symptom due to underlying conditions such as Parkinson's disease or neurodegenerative disease. I think that's my talk come to a close, so I'm going to ask Dan and the panel to come back to join us.
All right, here we are. So Jordy and Wanpen and Keith, thank you for those great presentations. And to the audience members, thank you for great questions. You've been just so active in the question space, and we're grateful for that. A good question. So let me begin with one of the ones that's fairly common here, and I'll ask Jordy and Keith both to respond to this. Jordy, I'll start with you. A number of questions about why the guideline does not give a preference of angiotensin receptor blockers over ACE inhibitors because of the side effects with ACE inhibitors. So I will be anxious to hear your response as well. And then Keith, I'm going to give you a chance to rebut what she says.
As a full disclosure, I am a PI or co-PI of a very large NIH study evaluating this right now. But it's a really great point that people brought up in the chat. So ARBs tend to be better tolerated. There's not this risk of dry cough that you see with ACE inhibitors, and you don't see this higher risk of angioedema that occurs, particularly in Black individuals, with taking an ACE inhibitor. And so intuitively, it does seem that ARBs may be the better choice broadly, but there's some judgment involved. There had been meta-analyses. There was one particular meta-analysis that was done that suggested that ACE inhibitors may be linked with better overall cardiovascular risk profile than ARBs. In particular, they found that in trials that had looked at long-term follow-up against placebo, that ACE inhibitors seemed to have better long-term outcomes than ARBs did versus placebo. Keeping in mind that ACE inhibitors came out about a decade and a half before ARBs did, and the groups that they were being compared to had things like statins in the ARB groups and had other risk modifiers that did not exist during the ACE inhibitor trials. In the trials that compared them head-to-head, there was no difference. And so I'll leave it at that and let Keith add anything else from his perspective.
No rebuttal. If you look at On Target, in which telmisartan, the long-acting ARB, was compared to an ACE inhibitor, the cardiovascular outcomes was the same. I think we have a very powerful way to determine risk, and that's to measure blood pressure. If the person responds to the ARB, I'm satisfied that they will get similar benefits to the ACE inhibitor. In my short remarks, I did mention in the 35-year-old Black guy who came in that for first step, we use equipoise for ACE inhibitors or ARBs. But if that person had had a recent myocardial infarction, or if they had heart failure with reduced ejection fraction, there are more data in those particular patients, very high risk with ACE inhibitors than ARBs. One caution. Sometimes we as clinicians are driven by insurance to use certain classes, members of a class. For instance, losartan, they love it. It's cheap, it's readily available, but it's a prodrug. It takes about 40% of its active moiety to actually come into play. And there are studies that it doesn't really have the same blood pressure reduction. So kind of resist just jumping to losartan because the insurance carrier says that's the ARB you need to use. There's irbesartan, long-acting, telmisartan, long-acting, olmesartan, long-acting. So some ARBs are a little better than others. Dan, if we get chance, I want to flesh out a little bit more about that question in terms of race. And I certainly didn't want to make it to appear that there are no social inequities in this society. We know that the white-black death gap driven by cardiovascular disease, uncontrolled hypertension, heart failure, chronic kidney disease is real. So in no way am I suggesting that that's not a problem. But if you lower blood pressure, you do it effectively across the classes of medicines that we recommend. And for high-risk patients, if you use combination therapy, it blunts any difference you see across what's basically a social category of race.
All right, Keith. So that was my next question. Have you
answered it already?
Can I add to that? John Flack wrote a lovely paper on this that was in American Journal of Hypertension last year, where he went into detail, particularly that when we tried to use race-based drugs, we didn't see any benefit in blood pressure control. It failed Black individuals. And so really the key is get people under control and stop thinking too deeply about some epidemiologic or post hoc analyses that may or may not have demonstrated particular benefit in a group that wasn't, where the data weren't really collected to represent the individuals that are actually sitting in front of us.
And can I make one more clinical pearl? Now I know
Yes,
you have
you
to
may.
move on to other questions. In the South, where you have a large amount of patients who consume really high levels of sodium, you have more obesity, you have more diabetes. In those particular patients, it can be blunted with an ACE inhibitor or an ARB. So what we may see in some of the racial differences in some of the smaller studies, they don't control for body weight, sodium intake, other things that may blunt some of the effects of the ACE inhibitor as a first step agent.
Let me just add one more comment about this. So those of you who are watching us closely are aware that two things have happened related to race. One, the new PREVENT calculator uses social drivers of health as opposed to race in its calculation, and then the blood pressure guideline for the first time in a bit does not use race as a differentiator for choosing therapies. And I want to underline what Keith has to say. So I've spent most of my career treating patients in Mississippi, and most of my patients have been Black patients. And I will say, when these changes occurred, I personally had an emotional reaction to this, that, it just sends a signal that people will think that our race-based inequity is behind us. And that's, as Keith has said very clearly, certainly not the case. But I am convinced that a race-neutral approach to risk calculation and to therapeutic decisions is the right way forward to best erase those health inequities. If we apply the guideline information to everybody in an equitable way, then we will eat away at the race-based inequities. So anybody else, Wanpen, you want to weigh in here on this, or anything else from Keith or Jordy?
No, I couldn't agree more. I think that the perceived blunted response is now in black. Usually the race different went away after addition of diuretics. No, couldn't agree more.
All right, so Wanpen, let me go to you. You've asked the clinicians on this webcast to do two really hard things. One is to let people go home with a blood pressure of 180 over 120 without parenteral medication to lower blood pressure immediately. That's a change in practice for sure. I'm not sure it's a change in evidence, but it's a change in practice. So tell us, the clinicians, how they follow through with management of those patients. When do you think they need to see them back? How do they need to keep track of the blood pressure of those patients over the next few weeks?
Yes. So I think that I think we always have intention to help the patient. But I think first thing we have to remember that intensify treatment immediately and try to get it down to normal. Actually, if anything, it might hurt the patient than helping. And we see this in the inpatient setting or in the ER when the patient comes for something else, come for med refill or something else, that they have a dizziness and they can't leave the ER because the blood pressure is rapidly lower. I think for the clinician is to make sure that the patient understand what they're supposed to take, and get them on the right regimen. When instead of like doubling the medication, I often tell other people doubling the medication is not doubling the blood pressure reduction. You get only 1/5 of blood pressure reduction. So I would review the medication that they're taking and make sure they're on combination therapy, or if the blood pressure is that high, we should probably make at least 3 drugs. But make sure patients understand what they're supposed to take and keep track of home blood pressure, and have them come follow up in a close range of 2 to 4 weeks, and also make sure that they can afford the medication as well, because sometimes when they are putting on medication and they have insurance, it doesn't mean they can afford the copay, and sometimes they are put on medication that is insurance doesn't cover. The copay is very expensive, and they don't want to tell the doctor that. So I think there's a lot of things we could do.
All right, so here's another question for Jordy. The question is about using potassium-enriched salt substitutes. And is this really safe to encourage our patients to use a potassium-based salt substitute? And who do we need to think about caution with potassium-enriched salt substitutes?
It's a great question that came up. And so it is safe to do from a hyperkalemia standpoint, coming from a nephrologist, except in individuals with more advanced chronic kidney disease. If the eGFR is less than 20, those are the individuals we worry about having a higher risk of hyperkalemia, and not all of them do. If you're monitoring potassium levels and you see that their potassium level is running closer to under 4.5, for example, they may actually do just fine with potassium-based salt substitutes, even in more advanced stages of chronic kidney disease, but that should be under the management of a nephrologist. The general population and individuals with chronic kidney disease stage 2 and 3 should all be relatively safe on a potassium-based salt substitute, except for very specific contraindications like a renal tubular acidosis type 4, which I hope most of you aren't managing. And so general population, safe, recommended, and effective, highly effective on a population level.
Dan, can I add?
Yes, please.
So I agree, Jordy. I think the community-based interventions, there was one in Peru that showed it did benefit blood pressure control across the population. And in the Chinese study, not only did it decrease blood pressure about 3 millimeters of mercury, which in a large population is significant, but it decreased cardiovascular events and total mortality. However, in the American population, we tend not to prepare as much food at home as we had in the past. So if you were a public health official, you really wanted to address hypertension, let's say, for instance, in most Americans, I would say decrease sodium, start to decrease some of the processed foods, the takeout foods, the drive-through foods. They're so loaded with sodium that just adding potassium is not going to counterbalance that profound effect on high sodium in that population.
All right. So this is a question for any of you who want to address this. Some have raised concern that we have increased the amount of medication for patients with high blood pressure on both ends of the spectrum. We have a recommendation to treat everyone with stage 130 to 139, with medication if blood pressure is not controlled within 3 to 6 months with lifestyle therapy. And then we've asked clinicians to consider 120 as the goal systolic blood pressure, and that will take extra medication to get lower than 130, and certainly from 140. So should clinicians be concerned that we're recommending too much medication, that we're over medicating the American public with this guideline?
Well, first of all, I specifically said that the guideline gives 3 to 6 months of appropriate therapeutic lifestyle interventions. If the person is going to embrace it and change lifestyle, stage 1, low risk, then I'm all for it. The problem is even many patients who are successful initially have a lot of recidivism, and we now know in observation in large cohorts, thousands of patients, they don't stay at a stage 1 low risk. The risk increases. Left ventricular hypertrophy increases. About 30% of the patients over 4 to 5 years will go from stage 1 to stage 2. Things fall apart. They don't stay the same. So if we're going to do lifestyle therapeutic interventions, I agree that's going to be your first step. It's the bedrock of care. It should be continued for all patients. But it's not going to be the way in which we're going to control blood pressure in many of these high-risk patients. The other thing is, I'm opposed to this idea that medicines are inherently bad. The newer antihypertensive agents, especially low doses combinations, are well tolerated without really significant side effects. Outcome data are real. A person who has significant blood pressure after 2 to 3 years in the VA cooperative study from the 1960s, half of them had a heart attack, heart failure, stroke, or were dead. And I tell my patients, I don't want you in a placebo-controlled trial.
All right, Wanpen, Jordy,
Yes.
any comments?
Yes, I want to also add that we could also help with the pill overburden by, as Keith mentioned, use the 2-in-1 combination, and actually many of them are now become generic. So we have many choice of inexpensive combination, and even at Parkland, our safety net hospital here, we have telmisartan HCT generic, benazepril amlodipine is now generic. Losartan, lisinopril combination with thiazide are all generic. And so the patient oftentimes do not care how many drugs are being treated, but they care about how many pills they have to swallow every day. So I think that physician themselves, we can try to look into this alternative and make the the pill overburden and adherence a lot improved with this consideration.
And I'll add to that effect, somebody asked a great question in the chat, when you're starting these single pill combinations, how do you know which one is causing an adverse effect, and are you concerned about starting these? They're incredibly important to reduce pill burden, as was just mentioned. And we really have found in all the literature and all the studies that have, the trials that have evaluated these drugs, that typically the side effects are pretty idiosyncratic to the class. You get edema, it's from a calcium channel blocker. You get hypokalemia, it's typically from the thiazide diuretic or hyponatremia. You get hyperkalemia, it's from the A or B or ACE inhibitor. The things that are not as idiosyncratic are if somebody has a true drug reaction like anaphylaxis, in which case an allergist would likely need to be involved, or of course that's an entirely different situation, but much rarer. Typically the side effects and the adverse effects are very specific to the drug. So I think that that's something to really be thinking carefully about, that it shouldn't be a barrier to using these. If a patient is dizzy, that's one that you usually can't target a drug to, but I would encourage you very strongly to be getting out of office blood pressure monitoring if you haven't already, because that's usually my clue to white coat hypertension or effect.
All right. So I've got questions about two drug classes. And this is for any of the panelists. So I'm making this one up a little bit. I'm an older clinician, and I'm in love with beta blockers. I've used beta blockers for years, and I think I've been pretty successful. Your guidelines don't put beta blockers in that list of 4 categories of drugs that I'm supposed to be using. Really, can I use a beta blocker? Won't that be okay?
Well, again, we look at outcomes. We don't just guess. The outcome studies have indicated that beta blockers, especially in older patients, tend to not protect as well against stroke and even, surprisingly, heart attack, as will the other classes, including the thiazide type diuretics and the dihydropyridine calcium channel blockers. On the other hand, we talked about these compelling or complicating indications. If a person has HFrEF, there are 3 classes of beta blockade that are very important. And we know, for instance, in some African Americans, they can have substantial hypertension along with heart failure. In that particular case, of course, you use carvedilol, bisoprolol, one of the proven long-acting metoprolol succinate, not tartrates. But for conventional, uncomplicated hypertension, the data is just not as robust that beta blockade, especially in older patients, is protective, as well as the 4 classes that we looked at.
And would you recommend that I change my practice patterns and not use the beta blockers, but use one of those 4 recommended classes, even though I'm reluctant to do that?
You know, change is hard, but things do change based on evidence. And the evidence, for instance, with the 4 classes was based on a systemic meta-analysis of over 22 studies, 148,000 patients. And those are the medicines that came up to the top as being most efficacious for blood pressure control. I'm not going to make the case that if you have an older person, especially if they're on a thiazide beta blocker, the electrolytes are okay, they're feeling fine, to suddenly withdraw medications. But initiating medicines, I don't think you can make a good case that adding the beta blocker as a first step is the way to go.
Okay. All the panelists? Thank you, Keith. Okay. All right. Now, the other class is maybe brought up by some of the younger folks. So these new drug classes that are helping people lose weight and managing diabetes, and last I read, if you take them, your tires will last longer and you won't have to buy as many tires. I mean, they seem to do everything for people. So why haven't you recommended that we start these new drugs on everybody with hypertension?
Well, we
Go
did
ahead.
mention, go, Jordan. No, you go. I just had the last one.
And so, I mean, as I mentioned, most of these trials, patients were on background ACE inhibitors and ARBs or background antihypertensive therapy, and these were adjunctive treatments. They do slightly lower blood pressure. I think they're really, really amazing in terms of cardiovascular risk reduction. But again, they're not treating the blood pressure entirely. They're not nearly as efficacious as our first-line antihypertensive therapies. And so we should be thinking of them as important adjunctive therapies, but not as the primary antihypertensive therapies.
Okay,
Cost
Keith,
then becomes I was going to say cost again becomes a barrier.
Yeah.
Certainly, if the person has diabetes, no doubt there's medication in the incretin class, the GLP-1 receptor agonists that are beneficial. And with renal disease, Jordy will tell you about the FLOW study with semaglutide. Only 1 milligram seemed to benefit persons with diabetes, chronic kidney disease, sleep apnea, higher doses of semaglutide. So there are doses, there are medicines in that class which are beneficial. But for hypertension, we have very effective, cheap, $4 in the big box pharmacy drugs that will help control blood pressure. And I'm going to say it one more time, Dan, America needs to get away from this thing that medicines are bad. Your body doesn't know whether you're getting it from a health food store or somebody in a dark alley. It's what works. And if you're using a prescribed medicine at the appropriate dose, you control for side effects and complications, you can decrease cardiovascular morbidity and mortality, decrease dementia. And this is what the people need. They need to be protected, not for our favorite supplement versus giving them the medicines that really help.
Thank you, Keith. All right. Here's one that's an interesting question. we suggest the mineralocorticoid antagonist for resistant hypertension. Why not just start everybody? Why don't we put that in that group of drugs to start with? Why don't we give everybody spironolactone or eplerenone, since it's so dandy at improving resistant hypertension?
I'll take this first. So
Okay.
I think that's I think that's what is recommended anyway on the fourth drug. But the I think if it's uses the first drug alone, it might not be necessarily more effective than the ACE inhibitor or a calcium channel blocker. So the data that's is being used, that's more utility in the resistant hypertension. I was doing clinical trial where I compare spironolactone to cortisol, and they actually, when they first use a single agent alone, it's not necessarily more effective than thiazide diuretics. If anything, you probably have to use a lot of spironolactone to get the same effects. I think that for resistant hypertension, it makes sense. It screen out people who already not adequate responders to RAS inhibitor, calcium channel blocker, and a thiazide. So that leave with one mechanism that has not been fully addressed as mineralocorticoid excess. So I would not necessarily I would think that spironolactone or eplerenone is the DNO for all forms of hypertension. That cannot be the case.
Mm-hmm. Other comments from panelists?
This is part of where screening people earlier may be really helpful, is guiding that therapy. And so that's part of why that's something that we're recommending considering now, is screening people with stage 2 hypertension with a renin and aldo. That's cost effective in other countries. That's not been assessed in the US, but we think that it likely would be something that can help guide this and help us determine in whom this would be an appropriate first-line therapy.
So the 4 classes that are recommended as initial therapy all have trials with hard cardiovascular outcomes, not just blood pressure. Should, if we move toward more use of spironolactone and eplerenone before they make our list of 4 a list of 5 classes, should we wait until they do mortality trials as single agents before we would consider putting them in the top group?
Not necessarily. Blood pressure is a very good surrogate for cardiovascular outcomes. And the FDA now will allow medications which have not yet done an outcome study but have been shown to be safe and effective for blood pressure lowering, to mention that blood pressure lowering reduces cardiovascular events, morbidity, and mortality. So it's a really good surrogate. We don't have many biomarkers or tests that are as good as blood pressure. The problem is we don't do it right. The patients are walking in the clinic, they're talking, their arms dangling, sitting on the table, and that's why we put so much emphasis on the correct approach to measure blood pressure. The other thing that's really in the guideline, Dan, and I know you mentioned it, but I'm going to kind of amplify, is home blood pressure out of the office. It tells us what's happening in that person's home milieu, that home environment. And there are several studies that it also helps patients adhere, because now they can see and understand why it's important to take their medicines, or for those who don't want to take medicines, adhere to a therapeutic lifestyle.
Okay. All right. Anybody else? Any final comments? I'm about to wrap up for the panel, and Alice is gonna wrap up for the audience. Any last comments?
Yeah, I'll make one last one. I think it's great what the guideline committee has done, and Dan, we appreciate your leadership. Blood pressure is the most prevalent and potent of the cardiovascular risk factors. Cardiovascular disease, #1 cause of death across all race ethnicities. But we need to apply these medications, lifestyle, and apply them appropriately, regardless of race, ethnicity, social class, or geography. And if we don't do that, we're not doing the right thing.
Thank you, Keith, and I thank all of our panelists today for sharing your expertise. And I give a special thanks to all of you who've given up an hour and a half of your time with your patients, with your families, to learn more about the high blood pressure guideline. And we wish you the best as you read these guidelines and our recommendations in the guideline, and as you move forward to reduce risk for cardiovascular disease, for kidney disease, and thankfully for dementia with your patients. So Allison, we'll turn it back to you. Thank you.
Thank you so much. I just want to echo my thanks to all the speakers for your insightful presentations and discussion. You bring the science to life. You've highlighted some of the changes. So again, we encourage everyone to read the guideline and use it as an ongoing reference for your care. Target BP resources have been updated to reflect the new guidelines. So we encourage you to visit the site and download quality improvement tools, practice resources, and patient education tools. There you can find more on-demand continuing education programs like this one that address accurate blood pressure measurement, treatment, lifestyle change, and self-measured blood pressure monitoring. Consider requesting our newsletter where you'll find out about future events, as well as to request additional guidance for your quality improvement efforts from the AHA and from the AMA. We have more than 2,300 organizations every year submitting their data annually for awards, where we recognize organizations who have committed to improving their blood pressure control, who have adopted evidence-based practices, and who have also achieved high blood pressure control rates. And so for those organizations, we really want to recognize their amazing work. So we certainly encourage you to do that. Lastly, I just want to mention that you will receive, when you sign off, a prompt to respond to a post-event survey. You'll also receive it in a post-event email if you registered in advance. We really welcome your feedback. Help us understand how we can support rapid adoption of this new guideline. The QR code that's on the screen here, and there's also in the chat, can be used to claim your continuing education credit. So we hopefully you'll take advantage of this opportunity. Again, the event is been recorded and it will be available shortly on targetbp.org, and it'll be announced in our monthly newsletter. I want to thank you for joining us. I want to thank you for your participation in the polls, for your very thoughtful questions. We got to them, as many of them as we could possibly in the time we have. Thank you for your renewed focus on blood pressure control and the care that you provide your patients every day. Have a safe and enjoyable holiday weekend. Thank you.